Hello again. I'm going to speak about chemical assessments and what they are used for and to break down some of the different levels of care to help make it make more sense if it's not super clear. As it wasn't for me when I was a new LADC. I feel like I got thrown in the deep end and I needed to learn the language and the different options available, and I needed to learn it quick. So, before I forget this, I will say, I'm not sure if I mentioned this in another video, but if you are looking up resources for clients, or if you're looking up, let's say, therapists in the community or medical providers that prescribe Suboxone, and you find somebody, I would make a list of it and I would hold on to that list and make a binder of it and hold on to that binder because you're going to need these referrals in the future. And it takes a lot of time and effort to get that list, and it makes no sense to recreate the wheel every time. And kind of along along those lines, when you go to professional conferences or trainings, it's a good networking opportunity to meet other providers, see what they do, see what they have to offer, and add them to your binder. Because that's going to make it easier when you actually refer people and getting them in the right place. So, in the state of Minnesota, a chemical health assessment through the state is called a Roll 25, and that's based on a funding stream. And so that's where the name came from. That's the type of the funding. And it assesses 6 dimensions. So those dimensions are intoxication withdrawal, biomedical, psychological or emotional behavior, cognitive, readiness for change, relapse, continued use, and then problem areas, and the recovery environment. So the first one that you are assessing is withdrawal and acute intoxication. So if somebody is acutely intoxicated, you stop the assessment and you might refer them to detox or tell them to come back at another time. It's just not going to be a useful tool. I know different providers take different stances on this, but as a general rule, I work in a private practice, outpatient private practice. If somebody shows up intoxicated, I stop the session, and then I tell them to reschedule. So, maybe consider what are the pros and cons of that and where you land on that issue. And it would be useful if you're working at an agency to know their rules on it. So, alcohol and benzodiazepines, depending on the use and severity, can be lethal in the withdrawal phases. And so they can be, it could be prudent to send them to a detox facility or a hospital so they can be medically monitored as they detox. The other the other substances like heroin or opiates or meth can be very unpleasant but not lethal. So it can be useful to have a place to detox. Can often take several days. There's going to be a lot of sleeping, nausea, vomiting, maybe. So having fluids on hand, having someone that can help take care of other responsibilities might be necessary. Or if you are working at an inpatient setting, they could withdraw there. So it's just determining whether a higher level of care is needed in order to get through the intoxication and withdrawal. The next dimension is biomedical. So you're assessing physical health conditions that either need to be addressed immediately or can be addressed concurrently in treatment. Is there hypertension, or is there something that needs to be medicated and addressed by a doctor? Or is there something that's more acutely medical that needs to be addressed urgently, like an urgent care ER or hospitalization referral, to address it right away? Pregnancy is one of those. Detoxing or withdrawing when you're pregnant should be monitored by a professional, and then just keep in mind that might also need to be reported as a mandated report. And so as a licensed chemical health professional, you will be a mandated reporter and will need to report harm to self or others, or abuse or neglect, or suspected abuse or neglect of a child, vulnerable adult, or the elderly. So giving that warning ahead of time to people is part of informed consent, even in doing an assessment. The next area is emotional, behavioral, cognitive, and that can, involve psychological as well. And so, similar to the previous category, you're looking at, are there any other diagnoses or other concerns that need to be addressed more urgently? If someone's actively psychotic, it's hard to determine, is this based on a psychiatric diagnosis, or is this, because of methamphetamine use, say, are they having hallucinations because of a diagnosis or because of their use? And so the technical rule is that it should be 90 days before you give a psychiatric diagnosis to somebody, 90 days sober, because it just looks so similar during that acute phase. So it can be a little difficult to distinguish, but if the individual has a known history of a psychiatric disorder, then it's useful to send them to a treatment center that addresses both mental and chemical health at the same time. The next factor is readiness for change. So motivation is a key part of people getting well. And often motivation is a hard thing to muster and a hard thing to maintain. And so matching that they're at the same at an appropriate level. So somebody who might have very low motivation, but high risks in other areas, like they're homeless, or they have medical or mental health issues, or they're financially in a tough spot. If their motivation's really low, they might need to be in a more inpatient setting where they're more monitored, they have more support. So make sure that they're matching and appropriate. And also, if somebody is not motivated at all, a once a couple evenings a week outpatient might be an appropriate referral. They might be willing to do that, or it might not be an appropriate referral because it could be so easy to just not go. So that's just one of the factors that you assess for. Relapse, continued use, or continued problem potential is the next category. So that's looking at have they tried to cut down or quit before? How many times? What's been successful? What's been unsuccessful? What resources are available in their life to help them in making these changes? What would be helpful in making these changes further? So this is really tapping into the client's own insight into what they've tried, what's useful, what's not useful, and then trying to find a treatment that matches that. So some people have concurrent eating disorders, and maybe the eating disorders really triggers the chemical health use, or maybe vice versa. And so a treatment program that addresses both might be really appropriate. And then finally, the last one is recovery environment. And so this is kind of getting a picture of what the rest of their life looks like. Are they working? Are they in school? How do they spend their free time? And kind of woven into these are criteria from the DSM-5. And so, how much time is spent finding the substance, using the substance, and recovering from the effects of the substance is, the DSM qualification is a great deal of time is spent doing that. And so, if the individual isn't working and they are regularly trying to get enough resources to be able to buy the substance, to use the substance, and then they, spend the next morning or half of the day recovering, that paints a good picture into how severe their substance use is. A general rule of thumb in medicine and in recovery is that to use the least amount possible. So if you have a headache, it makes sense to use the smallest dose of Tylenol to see if that's effective, rather than, pulling out all the big guns right away. And it's a similar idea, using the least restrictive means possible. So inpatient locked psychiatric unit is often not needed for everybody initially. And so that actually reminds me, part of the Rule 25 is having 2 individuals from the person's life speak to their addiction, just to help paint a full picture of that. But also keeping in mind that loved ones are scared and maybe at their wits' end and maybe tired and maybe have their own stuff going on. Often they might have codependency or they might have their own addiction, and so not putting full weight onto what the loved one says, but also keeping it in mind. So the loved one might say they need to be locked up and that's the only thing that's going to work. Well, okay, keep that in mind, but also the least restrictive principle, because you can, if that's not effective, then you can refer up or you can refer down on the level of intensity. So just some general options. Oh, and at the end, you can ask the client, is there a specific treatment that you want or specific type of treatment that you want? Do you want to go to inpatient? Do you want it to be all men or all women? An interesting side note on that is that women statistically do better in treatment with just women, whereas men do equally well in treatment with all men or co-ed. So, if someone's requesting, oh, I want all women or all men, or I want it co-ed, digging into that. Why do you want that? Is it because you feel safer? Is it related to trauma? Is it because you're distracted and you're looking for a partner at this time and you don't think any of this is really worth it, but that's the only way you're going to get someone in, so weighing these factors. So just general level of care options. Very least restrictive would be support meetings. So Alcoholics Anonymous, Narcotics Anonymous, and keeping in your back pocket other non-faith-based or anonymous meetings. So there are NAMI, National Alliance of Mental Illness, has groups for individuals, particularly with co-occurring disorders, mental health, chemical health. There's SMART groups, which is a more cognitive behavioral therapy based support meeting, which has a lot of resources online, a lot of worksheets, a lot of kind of doing your own self-therapy to understand why you use and other strategies to do instead. There's Women in Recovery, I think is one. There's Celebrate Recovery. So just having in your back pocket options, because more and more frequently I'm seeing people who do not want to go to AA or NA meetings for various reasons. But also, digging into that a little too, like is that because you're not ready to change, or is there something specific about it? Have you actually attended a meeting and have real objections? Because a rule of thumb is to say, okay, try a meeting 3 times, and if you don't like it, try a new one. And then another common recommendation is 90 and 90. So encouraging people to attend 90 meetings in 90 days. What I like about AA meetings is that it's a built-in support system. It's already there. It's already up and running. If you travel, there are virtual meetings, so it's already there. You don't have to recreate it. You can just kind of plug yourself in. And even if it doesn't fit perfectly, you can get around people who want to be sober. After that would be outpatient. So there's different frequencies of it. Often it can be, 1 to 5 days a week. And usually the way that it works is that you start with more meetings a week and then you decrease over time. There's intensive outpatient with lodging. So that would be you live somewhere else. You live at a different site. You bus in or you walk in or you drive in each day to the outpatient meetings, and then you go back and live in that group setting. There's halfway houses, sober living environments. Often those come after treatment, but sometimes that can be a referral where you live there and then you again attend an outpatient setting. There's inpatient, where you are living where you're attending treatment, and often, not often, but sometimes those treatment centers have then an outpatient option where you come later after you've kind of graduated or completed that phase of treatment. And then there is inpatient hospitalization, which is usually, if not always, locked. And so you're not coming and going. And that is often not an option unless people are a harm to themselves or others, and might either be on a commitment or they're in the acute phase of, suicidal or homicidal ideation or just a really severe medical concern. So that is my overview of the assessment process and the level of care. I hope that was helpful. Thanks.